The upper GI specifically is a study of the stomach. So GI stands for gastrointestinal tract. So in your mind, you may be thinking that we're going to be looking at the entire upper gastrointestinal tract, which would be the small intestine and the stomach, possibly into the esophagus as well. But the upper GI by itself is primarily the stomach. The very first part of the small intestine, we want to see the emptying into the small intestine and make an assessment of the duodenum. But for the most part, we're just looking at the stomach. So sometimes we'll do an upper GI series in conjunction with an esophagram. And in that case, what we're going to do is we're going to have the patient upright. So you're going to stand the table up, make sure the footboard is on the table securely so that it does not fall off, cause the patient some sort of injury, and make sure it's on securely. And if we do it with an esophagram, then I would refer you back to the last video where I discussed esophagram and the videos and also the overhead images that we're going to take on an esophagram. Then after the esophagram, the radiologist or the PA or the RA, whoever's doing the examination, is probably going to do some fluoroscopy images of the stomach as well, and may include some overhead images after they leave. So our overhead images, if we do any, what they're going to include would be scout images. So it's going to be a KUB, regular KUB. The radiologist is probably going to come in and do some just kind of an overview scout with fluoroscopy, probably from the esophagus all the way down into the stomach, just taking a look at everything. And then our part in that portion of the exam is going to be basically assisting the radiologist by providing the barium for the patient. If we're doing an upper GI series, then along with the esophagram, you need to make sure that you have the carbon dioxide crystals that I discussed in the previous video available. You need thick, thin barium and a little bit of water, and keep the cup available because we're going to do some tests for reflux, and also make sure that you have those CO2 crystals available. So your patient preparation for the most part is going to be that the stomach has to be as empty as possible. So we want it to also be free of gas and the abdominal cavity free of fecal matter. So what we're going to do is we're going to withhold any kind of food or water for 8 to 9 hours before. So the patient's going to be at least NPO after midnight, and there's a good chance that they're going to have the patient not just NPO after midnight, but also backing it up to the evening meal and making sure that they have a low residual meal for dinner the night before and nothing after that. So we've got a couple of different options with the GI series, and that is single and double contrast. We also have biphasic examination, and then hypotonic duodenography is less common, but if primarily what we're looking for is duodenum, then they may select that rather than a complete upper GI. So with a single contrast, remember that anytime we're using an iodinated contrast, you need to review why we might use iodinated contrast. But anytime we do an iodinated contrast, a gastrographin or something like that, it's going to be single contrast. It's never going to be a double contrast. We just can't get a good study off a double contrast, or a good double contrast study off iodinated contrast. So if you're using the iodinated contrast, you don't have to have the crystals available or anything like that. If you're doing double contrast, then certainly you do. So what we're going to do is we'll usually begin with the patient upright. Radiologists may require images of the heart and the lungs as well, just to make sure that there's nothing that would indicate the patient has any kind of aspiration issues or anything like that. If a patient shows evidence of pneumonia, that could be an indication that they've got an aspiration problem. So they may alter their exam a little bit just to evaluate the swallowing mechanism. then the radiologist is going to instruct the patient to drink from a cup of barium. I mentioned before that the barium actually comes with some very thick straws. They're clear straws that kind of look like very thick oxygen tubing. And every department I've ever worked in, they had a tendency to take those straws and throw them away. And I never really understood why, because they have a large lumen, the lumen being the hole that goes through the straw. It's a very large lumen, and they can get more barium in through that straw. So they can get better filling of the esophagus. So I would recommend that when you see barium come into the department, snag a few of those, keep them available, and use them. But at any rate, your job at this point is just going to be to provide the contrast that the doctor is asking for. So if we're doing an esophagram along with the upper GI, then the esophagus is going to be fluoroed, and maybe some spot images are going to be taken with the fluoro tower. Once the barium is down into the stomach, chances are the radiologist is going to lay the patient down and then have the patient drink like an RAO drinking esophagus, like what we talked about before. So once the GI series begins, then what we're going to do is we want to make sure that the stomach gets as full as possible. So I'm assuming at this point that the patient's already had the CO2 capsules that will give us our double contrast. So at this point, the radiologist leaves, and your barium type is going to be dependent upon what you're doing next. So your radiologist may ask for thick or thin barium. If we're doing an esophagram, upper GI, small bowel follow-through, then to save time, that thin barium will go through the patient a whole lot quicker than what the thick barium will. So to save time, your radiologist may ask for thin barium. Most of the time, if we're just doing a GI series, it's going to be a thick barium. Air contrast with the CO2 crystals and thick barium in most cases. So the patient's going to drink more barium to fill the stomach up, and the air that's already in there from those CO2 crystals is going to give us our air contrast. Now, what we're going to be looking for anytime that we're doing air contrast, we're going to be looking really for the mucosal lining. The purpose for the air contrast is to give us some mucosal lining, images of the mucosal lining. So we fill the patient up with both air and barium. We have the patient roll around, and the barium coats the inside of that organ system. As it coats the inside of the organ system, naturally the barium is going to follow gravity, and it's going to go to the lowest portion of the stomach. That's going to be very important here in a bit when I talk about where you're going to see the barium, where you're going to see the air. So what we're looking for is any kind of defect in the mucosal lining. Like what I talked about in the esophagus, maybe a diverticulum, maybe a stricture. Stricture you can see without air contrast, but anything smaller than that, later we're going to talk about diverticula in the colon. It's very important to do air contrast to see exactly where all the diverticula are. But if we're looking for something small, mucosal lining defect like a ulcer, you're just not going to see that if you do a solid study. So you have to have that air contrast. Air contrast, always mucosal lining. So the procedure and the examination is going to depend on a lot of different things. So the time of the procedure is going to depend on peristalsis. Peristalsis is going to depend on the pathologies the patient may have, the metabolic rate. Sometimes it goes through really, really quick. But it's also going to depend on patient's body habitus. Where you have a patient who's hypersthenic, the position of the stomach is going to be different. I talked about that in the first video. Also, how much the patient can actually drink. Some of your patients are going to be it's going to be a hard sell to get them to drink a lot of the barium. But any kind of abnormalities or changes in function of the GI system can affect the length of the exam and the appearance of the contour of the anatomy. So what we're going to look at then are the overhead radiographs after the radiologist is done in the room. So our normal projections are PA. There is an optional PA axial. PA axial is typically just used for hypersthenic patients. We'll take a look at that and talk about it here in a bit. But PA oblique, which would be an RAO position, remember the difference between position and projection. Projection being the path of the beam, that would be your PA projection. RAO is a position. AP is LPO position, lateral, it would be medial lateral, and AP as well. Now the stomach lies in a couple of different planes inside of the patient's body. Let me get to the camera. So the stomach is not just straight up and down vertical in the patient's body. The upper portion of the stomach, this is the left-hand side, and the stomach is primarily on the patient's left-hand side, and the top of the stomach leans backwards, which means the bottom of the stomach leans forward. That makes a difference when we're talking about where is the barium, where is the air in the different projections. So if the top of the stomach lies posterior, think gravity. If the top of the stomach is posterior, if the patient's laying on their back, then the top of the stomach is going to fill up. The bottom of with barium. The bottom of the stomach is going to fill up with air, right? So the stomach is on the patient's left-hand side, but it's kind of J-shaped. So if the patient's laying on the right-hand side, then you got to, again, think gravity. So your test questions are going to ask you, where's the barium, where's the air? What portion of the stomach is going to be filled with barium? What portion of the stomach is going to be filled with air? So if the patient's laying flat on their back, think gravity. Barium is going to go, it's heavy, so it's going to go towards this side that's closest to the floor. Also, the stomach is J-shaped, so it's on the left-hand side, patient's left-hand side, and it dips in a J shape, and it points towards the right-hand side. So if the patient's laying on the right-hand side, then that's going to also fill up the lower portion of the stomach and into the pylorus and the first part of the small intestine into duodenum. So that's where the barium is going to be. So in each one of the projections that we're going to talk about, you're going to have to pick out where is the air, where is the barium. Now all you have to do is think of gravity. If you think of gravity, that's where the barium is going to be, and the air is going to be everywhere else. So positioning of the central ray. So I'm going to demonstrate this, but I'm going to talk about it also. We've got two different things, that is longitudinal positioning and transverse positioning. And students tend to get these two mixed up just a little bit. So your longitudinal positioning, that would be where you put your central ray up and down the body, in the length of the body, longitudinal positioning. And it uses the line of collimation that runs across the patient's body. And that seems a little bit backwards. You have a tendency to look at your crosshairs, and the shadows of your crosshairs, you tend to look at the longitudinal line of collimation and think that's your longitudinal positioning. But it's not. It's the line that goes across the patient's body determines your longitudinal positioning. And I'm going to show you this. I'm going to demonstrate it for you here in just a second. Your transverse positioning, that is your lateral positioning. So that uses the line of collimation that runs the length of the body, and it determines where the central ray is going to be side to side. So longitudinal positioning is up and down, and it uses the crosshair that goes across the patient's body, as opposed to transverse positioning uses the one that goes up and down the patient's body. Your longitudinal positioning is this. All right, so you've got the two lines of collimation that look like this. You got one that goes across the patient's body in one dimension, one goes up and down the patient's body this way. In order to position your central ray longitudinally, you have to take this line, and that determines where you're going to put it. As opposed to if you're going to offset, your longitudinal line of collimation is going to be determining where your transverse centering is. So your stomach primarily being on the patient's left-hand side, you're going to have to take an off-center longitudinally towards the patient's left-hand side. So if you have a patient who is asthenic, I refer you back again to the body habitus lecture in the first video on the GI alimentary canal, and the transverse centering is going to be way down in the pelvis. So longitudinal line of collimation gives you your transverse centering. Horizontal line of collimation gives you your longitudinal centering. Kind of confusing. So PA stomach duodenum, the patient may be upright, but most of the time after the radiologist has done their portion and they've left the room, the patient's already going to be down on the table. The table is already going to be horizontal. So what you can do is you can sit the patient up, have them drink the rest of the contrast, and then you can put them down, lay them down for the exam. So a PA stomach, the position there is going to be ventral recumbent or ventral. It's a decubitus position. We're not going to do a decubitus projection, but it is going to be with patient laying on their stomach. So it would be the position, the definition of the position would be ventral recumbent position. So what we're going to do is we're going to align the midline of the grid to the sagittal plane, passing about halfway between the center of the patient, mid-sagittal plane, and the left lateral border of the abdomen. Again, that's because the stomach in most patients is off to the left-hand side. If you have a patient who's very hypersthenic, you might not want to center that far laterally. Their stomach has a tendency to be more central. So your central ray is going to be about 1 to 2 inches above the lower rib margin. And if the patient's upright, then you're going to have to center lower. With gravity working on the stomach, if the patient gets upright, then the stomach's going to drop just a little bit. So your central ray is going to be centered to the image receptor. Your collimated field could be 10 to 12 inches, 10 by 12 inches. And again, that's the area on the image receptor. So use your dials on your collimator housing to determine 10 by 12. That 12-inch distance is going to be lengthwise on the patient's body, as opposed to the 10 is going to be crosswise on the patient's body. So you want to make your exposure at the end of expiration, and the reason for that is because as you inhale, then the diaphragm compresses the abdominal cavity and it kind of expands outward, and so it gets thicker. And you should know by this point that the thicker the anatomy that you shoot through, the more scatter radiation you create. So if you make your exposure at the end of expiration, then you create less scatter radiation and you should have a better image. And so where you should see the barium is going to be in the body, keeping in mind that you are PA, you're in a PA projection. So with PA projection, the patient in a prone position, then consider the position of the stomach again. The fundus, so the upper portion of the stomach, is going to be posterior. It's going to be up, and the bottom of the stomach is going to be closer to the image receptor, which means with the gravity, it's going to put the barium in the body. You're probably going to see some in the distal portion of the stomach down into the pylorus, but it's definitely going to be in the body. And you're definitely going to have air in the fundus, providing you use the crystals. So what your radiologist may ask you to do in this case, or what they might have done before they left the room, is try to demonstrate a hiatal hernia. Hiatal hernia can be a very subtle finding. So if we can increase the pressure in the patient's stomach, if they have a sliding hiatal hernia, then just increasing that pressure might provide demonstration of that. So the palparian is that paddle device that you saw in the last video. That's the actual name of it is palparian. They called it a compression device. In the PowerPoints, I added this in this particular slide. So palparian, or you can use a towel roll, just put it under the patient's stomach, increases abdominal pressure and may push the hiatal hernia above the diaphragm and make that demonstration. So you obviously you want presence of collimation. Make sure that your collimated field is 10 by 12. I think that's something that we've kind of gotten away from, is making sure we get tight collimation. You want to see the entire stomach. You want to see the duodenal loop. If you don't see the duodenal loop, we're going to do some specialty views for that. But you're going to want to see the pylorus, no rotation, exposure technique. You're going to want high KVP. You're going to be phototiming, so the mass is going to take care of itself, but you want to use 110, 120 KVP. So it looks something like that. You might have just a small amount of rotation. It's probably not going to be evident all the way down at the stomach. And this collimation is way larger than 10 by 12. This looks more like a scout image. Just not very good collimation at all. So what it should look like is that. So you see the fundus it's got air in it, and you've got the body. Most of the air contrast looks like it's dissipated if they used it at all. So in a lot of cases, you're going to see more air in the fundus of the stomach. But you've got the body. You're starting to see the duodenum. You're starting to see the first part of the small intestine. So what you're looking for then is that you're going to have barium in the body and the pylorus and air in the fundus for the PA projection of the upper GI. And there's another view of it. Oop. And another. I want to take a second and address something real quickly. I'm pulling from two different textbooks to appeal to a wider audience. And what that's going to do is it's going to introduce a certain degree of redundancy, especially in the positioning and also in the evaluation criteria for each one of the projections. I'm using both the Merrills and the Bontragers to pull some of the images and some of the positioning from. The positioning is really the same in both textbooks, so it doesn't really matter, but the positioning or the terminology may be a little bit more bulletized out of the Bontragers. So I want to leave both of those in there, and I'm not going to stop on every slide for long. So if there's redundancy, I'm probably just going to stop on one slide for the evaluation criteria, one slide for the positioning. I'll try to go slow enough through the redundant portions so that if you prefer the terminology on on one particular slide over the other, then you've got both of those. So another thing that I think bears pointing out is that Bontragers and Merrills are the most common two positioning textbooks, and they're the gold standards. So on the registry, when you get to the registry, what you're going to see is that regardless of whichever textbook you're using, the angulations, the positioning, the evaluation criteria fundamentally are going to be the same. And when you have two giants like Bontragers and Merrills, and there might be a difference between the two, then those differences are not going to show up on the registry. They're not going to select one over the other. If there's a 5-degree change in angulation in one textbook or the other, then they're just not going to use that particular information on the registry. So those types of things don't matter. But 99% of what Bontragers and Merrills say are going to align. So again, I'm not going to stop on every one. This is a slide out of Bontragers, and both of them are from Merrills, or Elsevier, I'm sorry. Both of them are from Elsevier, and it's just that Bontragers tends to bulletize more than what Merrills does. So again, PA stomach, we've got the body, we've got the pylorus, we've got the duodenal loop, that is the duodenum right there, and we've got an air-filled fundus, and the body is full of barium. So the PA axial, again, all of these can be done upright. I'm just going to really address the recumbent position. So the patient is going to be, again, laying on their stomach. You're going to align the midline of the grid to the mid-sagittal plane. We're going to center 1.5 or 1 to 2 inches above the lower rib margin. That's going to put us right around L1, L2, and that's for a sthenic patient. So if you have a hypersthenic patient, which is really what you should be doing the PA axial for, then you might center a little bit higher. Their stomach is more horizontal, and it's more vertical. If you have an asthenic patient, you may center lower. So what you're going to see if you're using Merrill's, if you look in the notes, what it says is the PA axial stomach was developed to open the high transverse stomach in a hypersthenic patient. So this might not be routine in all hospitals. PA axial may only be used in hospitals if you have a hypersthenic patient. So opens the high transverse or horizontal stomach in a hypersthenic patient. Again, since it's PA, we're going to have air in the fundus and barium in the body. And I don't have an image of that. If you happen to be using a Merrill's, then you can look in the Merrill's to see that. You might be thinking that it's going to be tough to find the lower rib margin with the patient laying on their stomach, and you're not wrong. So a couple of positioning tips that you might find helpful. One is lower rib margin is way down here. So that's bottom of the ribs. But just anterior to that, more on the side, is going to be what we refer to as the angle of the ribs. So it's a little bit higher, and it's pretty much where you want to center. It's about 1 inch to 2 inches above the lower rib margin. So that's the angle of the ribs. Problem is, some of your patients are going to be kind of goosey, and if you start using your fingertips to try to poke around and find the angle of the ribs, which is right here, they're going to be ticklish and they're going to run from you. But if you put your hand on the angle of your ribs, if you find it, the angle of the ribs is where the ribs come up and they make that turn to go up, towards the sternum. So it's kind of a sharp little change in direction right here. If you put let's say your right hand on your left angle of the ribs and straighten your elbow out, what you'll find is that it pretty much corresponds to the bend in the elbow. So if you have a patient, first off, if you have a patient, you can't find the lower rib margin, maybe they're quite large, you can't find it, they're running from you because they're goosey, what you might want to do is you might want to put your hand flat and feel for the angle of the ribs. So you can usually feel that a little bit easier, but put your hand flat. If you start poking with your fingertips, it's going to tickle them and they're going to try to get away from you. And if neither one of those work, then use the bend in the elbow. It's going to correspond pretty much the same spot. So next we're going to do a PA oblique of the stomach. It's going to be an RAO position. So you're going to bend the patient's left leg and bend their left elbow and rotate them up. Our degree of obliquity is going to be pretty broad, from 40 to 70 degrees, with a steeper degree of obliquity in your hypersthenic patients. We're going to take a look at why that is here in just a couple of minutes. But where we're going to see the barium now is in the pyloric canal and the duodenum. So remembering that our stomach is a J-shaped structure, then what we're going to have is, as we oblique up, the J is going to be pointing back towards midline. With the patient laying on their stomach, that's where the barium is going to be, is in the distal portion of the stomach, in the pylorus. And now we're really going to start to see that loop of the first portion of the small intestine, that loop of the duodenum. Our collimated field is going to be 10 by 12. Make your exposure at the end of expiration. Understand too that some of your radiologists prefer you shoot on inspiration. And if that's your protocol, that's your protocol. But textbook positioning says shoot on expiration. That's what you have to know all the way through the registry as far as tests go. So what we see then on the PA oblique is the pyloric canal and duodenal bulb in sthenic patients. Hang on to that. Sthenic patients, PA oblique for sthenic patients. Because once we get into lateral, then we're no longer going to see it in the pyloric canal and duodenum on the PA oblique, but we're going to see that in hypersthenic patients. And that is why it is that we oblique steeper for hypersthenic patients as opposed to everybody else. Also, because of the patient's position and the gravity pushing directly on the pyloric sphincter, your peristalsis is now going to increase. So in this case, what we may have to do is may have to take several images serial study just to visualize barium in that pyloric canal. So we're going to have air in the fundus, barium in the pylorus and duodenum. So that's what it's going to look like. You can see the distal portion of the stomach, the fundus is completely full. I think one of the textbooks is pointing that out as being a potential ulcer. So if you could imagine if this was completely filled with barium like what you see down here, you would not be able to visualize that at all. So we see the pylorus, we see the duodenal bulb. One thing that's important to note is that if you have a patient, you see the loop of the pylorus is kind of a C-shaped. If you have a patient that you've done an upper GI on, let's say they've had persistent pain right at the midline, you can't really say it's left quadrant, right quadrant, left upper, right upper quadrant. You can't even say it's epigastric. Then what you might have is the patient might have a tumor in the pancreas. The head of the pancreas sits right here. And what happens is that as that tumor grows, it expands that head of the pancreas, and this C-shaped loop here becomes greatly enlarged, and sometimes it'll almost look like a digital C, almost squared off. Excuse me. So evidence proper rotation or proper collimation, evidence of the proper amount of rotation, you see the entire stomach and the duodenal loop. And again, it looks like that. And we've got the barium in the body and the pylorus and the duodenal bulb. We also have the barium in. So now this is AP oblique of the stomach and duodenum. So AP oblique, now we're going to be in an LPO position. We're going to see the duodenum, but it's going to be elevated. So our degree of rotation again is going to be 30 to 60 degrees in this case, average at 45 degrees. So now what you're going to do is you're going to put the patient's left-hand side down to their side. You're going to put the right arm across their chest. You're going to bend the right knee up, and you're going to have the patient rotate towards their left-hand side. So you're going to be in an LPO position. Now you're going to make your exposure again at the end of expiration, and now what we're going to have is air in the body in the pylorus, and the fundus is going to be full of contrast. So that's what we should see is proper collimation. We should see the entire stomach, and we're going to see the duodenal loop, but it's probably going to be full of it's going to have an air contrast look to it, as opposed in the body and the pylorus, also double contrast look, as opposed to the fundus of the stomach is going to be full of barium. Again, the top of the fundus is more posterior, so naturally if the patient's laying on their back in any way, it's going to fill the fundus of the stomach. So it looks like that positioning wise, and the image looks like that. So the primary thing that we get in the pylorus and the duodenum is we get desuperimposition. Obviously we don't see the entire thing here, but we see the fundus of the stomach full of air, or full of barium, in the body and pylorus full of air. And again, looks like that. This is a much better image to show the loop of the duodenum. So your lateral stomach and duodenum, notice that your alignment is going to be midway between your mid-coronal plane and the anterior surface of the abdomen. So you're going to off-center just a little bit towards the anterior portion of the patient. So you're still at L1, L2, and you're going to put the patient in true lateral position. I'm not going to go back through what all that means. You should know by now what true lateral position means and how to get there. So what we're going to see then is the barium in the body, especially in the pylorus and duodenal bulb, in hypersthenic patients. Remember, RAO, sthenic, hypersthenic is going to be lateral. And it should look like that. So notice that your vertebra, if you have images on your test or on your lab practicum, the first thing that you need to look at, if you're looking at an image and you see air in the fundus and you can see the duodenum, then look at the vertebra. If the vertebra looks blocky like that, you're in a right lateral. If it does not, if you start to see those Scotty dogs or it looks like an oblique of the L-spine, then what you're going to be looking at is an RAO. So lateral stomach and duodenum is good for the pylorus and the duodenum in a patient who is hypersthenic. Evidence of proper collimation, all required anatomy. Make sure you use good technique. That's not the best image in the world, but you can still, again, you get a different look at a different patient, and what you see is, again, looking at the vertebrae, you can tell that this is lateral. One thing that I did miss earlier in the presentation, there was this reference here. So what we're going to see also is the retrogastric space. So the area behind the stomach is what we're going to see. In all of our other images, the contrast is going to be on top of that. You can't see that retrogastric space. So AP, stomach, and duodenum, this should be no, I mean, we've kind of had spoiler alerts if the patient's AP. Where's barium going to be? It's going to be in the fundus of the stomach. So this again looks more like a scout image rather than an AP of the upper GI. It looks like a scout. I say that because you've got collimation all the way over to the edge of the patient's stomach, and it looks like we're centered to the center of the patient mid-sagittal plane. So I would not call this an AP of the stomach as much as what I would call it a scout image. Plus, it looks like we're on a 14x17 centered a little bit high so that we could see the top of the stomach as opposed to just using the 10x12. So we went through that already. I just felt like it was a better place to include it earlier. But also consider your logical order of your projections. So the way this was presented was not logical. So what you want to do is you want to move your patient as little as possible. And that really becomes important whenever we get into barium minimus. But you want to move the patient as little as possible. So what you could do for an upper GI is do your AP, since you already have the patient supine, go ahead and roll them up into an LPO, roll them in the opposite direction to get to a right lateral, roll them down just a little bit to get to a RAO, and then flat onto their stomach for a PA. So in that case, you just rock them in one direction, and then you rotate them all the way around onto their stomach in the opposite direction until you get to the PA. PA axial if needed. Or you could go in the opposite direction with all of that. So you could go either from AP or PA. It doesn't really matter. Just rotate them one time. If you do something like AP, well, I did my AP, then I'm going to do my PA. You've rotated them once. Now I'm going to do my LPO followed by my RAO. You've rotated them again. And now I've got to go back to my right lateral. And it's just, it makes you look like you don't know what you're doing. So if you're new at this, what I recommend that you do is you write all this stuff down in order that you're going to take the images, and then just check them off as you complete each one. So AP, stomach, duodenum, that's what we're looking at there. And sometimes if we're doing a upper GI, small bowel follow through, the last image is fine to take on 14x17 as the AP, and just using that as your first image of your small intestine, or what we refer to as small bowel follow through. So what we're looking at again is the entire stomach. So the pathologies we're going to be looking at are a number of different things. We talked about peptic ulcer earlier, but we've also got a few other things. These are not really pathologies as much as they are foreign bodies amassed in the stomach. So it's a massive indigestible substance in the stomach. It's what we refer to as a bezoar. And it can be hair or it can be vegetable matter. In patients where it's hair, that would be patients who have nervous disorders that wind up, that have a tendency to chew on their hair. Our demographic is usually young women, or if we have somebody who's a strict vegan, some of that vegetable matter may not move out of the stomach, and it may completely eventually fill the stomach up. So, good reason to eat meat now and again. So, other things that we might visualize are cancers, carcinoma, gastritis, Hiatal hernia we already talked about, so we're not going to really spend any time on that. And then the peptic ulcer we've already seen. So that's a bezoar. So I don't know exactly what that is. I would venture to guess vegetable matter. Sometimes if it's hair, you can actually see the striations. So there are diverticula that you can see in the small intestine. This is one in the duodenum. We'll take a look at one in the distal portion of the small intestine we'll refer to as Meckel's diverticulum. Again, sliding hiatal hernia. I kind of talked about this before, that the image that I had up before had that same artifact on it. And I really kind of suspect that that was not an esophageal web, but really evidence of a sliding hiatal hernia. Or maybe not, I don't know. So without clinical correlation, you can't really tell. So gastritis is just inflammation of the stomach. So we've got thickening of the rugal folds. So the rugae are the folds in the stomach. And so they can thicken, or you can have just complete absence of those folds. So what do you need to know about an upper GI? Certainly know the prep. Know the order of the exams if we're doing multiple exams. So in this case, it will be esophagram, upper GI, small bowel follow through. When we get into the large intestine, again, there may be a little bit of a surprise for you there. Know the three types of contrast. Those will be your barium, your air, and then you've got the two combined for air contrast. But you can also use iodinated, but you can't do with iodinated, you can't do air contrast. I don't know what that next bullet point was. Obviously, I got distracted on that, and I didn't catch that before I started the presentation. Know your body positions, your projections, your image receptor locations, your central ray location, collimation, structure shown, and evaluation criteria for all of those. Know the ways to demonstrate the hiatal hernia. That will be put the patient in Trendelenburg, increase abdominal pressure, putting a towel roll or the compression device, palparian, under the patient to try to exaggerate that abdominal pressure to push it above. You can also, I'd remind you of the ways that we see reflux, gastroesophageal reflux, right? And that is to put the patient in Trendelenburg, maybe give them some water after the esophagram, fill the fundus up, lay the patient on their back and see if we have any kind of reflux. And then know your pathologies. So I hope you found this to be helpful. And if you did, please like, subscribe, and share. If you have any questions, please put them in the comments. And I thank you for watching.